Uh, so I'm going to talk to you this morning about the MVGL MR program and also Advanced HA. And first of all, I would like to introduce you all to concept of Advanced HA. Actually, I think both of all of you know about HA standard. And recently, we developed more contingency of HA standard, and we call it Advanced HA. For the Advanced HA, we actually focused on performance of the hospital. And the key characteristic of Advanced HA is the empowerment evaluation for the hospital. Can be, they can evaluate themselves. How can they evaluate themselves? They have to do things systematically and also using the evaluation guide in Advanced HA standard as the guidance to improve their compliance with the standard. And also we implement the concept of EIO, it means that evaluation, to do the self-evaluation, empowerment evaluation, and using the results from the evaluation to improve the performance of the hospital that we call the I. And also, after the improvement, how about the improvement to integrate between the system in the hospital? That is also another I. And also after the improvement and integration of all the system in the hospital, does it bring up the new system or new work process, like innovations of the system? That is also another I. So sometimes you might see that the EI in the power of 3. It means that improvement, integration, and also innovations that bring to the final outcome. That is the O over here. That is all involve the performance of the hospitals. So these pictures of the Dr. Anuwat is the main concept and also the key characteristic of Advanced HA. To doing this, you have to involve all the staff in the hospital to do for them to evaluate themselves and give them the opportunity for the review of their compliance, and also involving the whole organization together. This is also come in the same thing and also come along with the DNVGL MIR standard, because the HAI and also DNVGL, we're working together for a while for the surveyor trainings. And also, I think both of us learned a lot from each other for the implementation of the standard, because the main concept of the HA, as the Mr. Anthony Wetchmaker, who sit at the back, teach us that we need to be a student when we go to the hospital. We're not the inspectors, actually, the surveyors of the HA, we're not the inspector, we are the learners. We go there as the student. So we ask hospital, what do they learn from the risk assessment? What is the risk around here? And what do they learn? How they do that? Why they do that? So we learn from them. And that is the same thing when you're using the MIR standard. When we go to the area and we ask them whether they're concerned about the infection risk in the area. And also when they take care of the patients, what is the risk of these patients? What is the risk in this area? What is the specific risk for this particular patients? So all of this, we use the criteria and also apply to the context of the hospital. Ask the hospital staff, hospital leaders about the main purpose. What is the purpose of why they're doing this? What is the purpose? And also using this, how do they design the system to achieve the purpose? And how they learn from implementation of the program that they design. And if they learn from their implementation, learn from their working day-to-day basis, uh, what is the gap of the actions of the when the implementations of the program, and after learning, how can they improve to make the system become safer, to make their patients become safer, have a better outcome, and also achieve better care for the patients. And also, we have another word here, the core values. It is the core values of the standards. When you look at the back of the book, the standard book of HA, you will see all of the core values that are involving with the standard improvement or quality improvement in the hospitals, that are starting from leadership, visionary leadership, and also some standard that is this, or some core value involving with the learning from the patients or patients focus, and also the continuous learning. Also, that is the one thing, or evidence-based, that is also the core value in the standard. So we're using all of this together. Sometimes you will heard the surveyor say that they're using 3C, that is the using the criteria together with core value and apply with context to do the quality improvements in the hospitals. Actually, when you apply for the HA accreditation, we're using this score to measurement the improvement of the hospitals. If the hospital in the beginning phase, we actually give the score 1 or 2. That is the starting implementation of the system. How do they learn from the system? If they learn from the system, do they have the systematic way to handle with the situations? If they have a plan or have a starting implementations, do we achieve the last score of 2 out of 5? And if the process of implementations is all over the organizations and do it systematically, and also integration between the system, for instance, the risk assessment, infection control, and also the environmental control, facility management, medication management, if the integration together, do we achieve the early result, like to having 2.5 out of 5? That is the early phase of passing to have accreditation from HA. And also, for the advanced HA, we expect that the hospital will achieve at least 3. It means that for the result is average or above average. And also have implementation systematically. Sometimes some hospital might have above average result in some area. It doesn't mean just the clinical result, but it means that the result for the quality improvement. So many hospitals regarding this as the clinical result only, but it's not true. If they say that they're excellent in caring of head injury patients, it's not just that. It's involving with the quality improvement systematically. We will ask them, what about the medication management? What about the risk assessment? Do they have a systematic way to handle the risk when they occur in the hospital? How do they handle the incidents when it occur in the hospital? So we ask them and we learn from them how they're doing this, and do they do this systematically, and after that we evaluate the hospital. So if the hospital achieve the 5, it means that the hospital become a best practice in quality improvement, and also become the place for others to learn from. Actually, HA standard is developed from the concept or uh, the key area here from Malcolm Borish National Quality Award. That is the performance excellence framework. So I think many of you quite familiar to this framework. However, the thing that I would like to emphasize is don't forget the organization profile, the context. Because with this framework, you need to adapt with your context and to learn from your context. Because it's not the rigid framework, it's kind of a philosophy. If you want to improve the hospital, improve the quality of the hospital, you can start from anywhere here. That is we call the leadership cycles. You can start it from leadership, or you can learn from organization profile, and then the leadership have visions, and then start it from strategies. However, you have to focus on your customer or your patients. And if you have this, you will consider that how can you achieve without people? Because the hospital is not just the building. The hospital is the people and also the system inside the hospital. So you consider workforce. How about doctors? How about nurses? How about the support? And how they're working together. So like the MIR that Paul said, how can you empower your hospital staff, your support staff? How do they know their important role to caring for the patients? Caring for the patients is not just the doctor, it's not just the nurses, and it's also involving with the porter, it's also involving with the housekeeper, it's also involving with the security in the hospital. How can they raise the importance of their staff, and how can they implement the learning process to their staff all over the organizations. So the HA standard, with this framework, we move to here, the part 1 of the HA standard. And for the process management, that is the operation here, we classify into detail for the cover all the system in the hospital. We call it part 2. That is the key hospital system. So it starts with the risk and safety management. Professional governance is cover doctors and nurses. Environmental of care is cover facility management and also infection control. That when we work together with the DNVGL, we learn from each other, and we found that for infection control, even with the concept of managing of infection risk and use the risk assessment concept, we can expand to every system in the hospital. We use the same kind of concept to implement to this. How about the environmental of care? If you look at the environmental of care with the risk assessment, to do the risk assessment for environmental of care, how you handle the wastewater management, how can you handle the ventilation in the room, in the patient's room, how can you handle the bed, how you organize the thing in the patient's room. That is sometimes you call it 5S. So it's raised the importance of the organizing everything in the hospitals. And also the medication record system. If you look at the medication record with the eyes of a risk assessment, what is the importance of medical record? And what is the risk involving with the medical record? Also the medication management, that is very clear. and also disease and hazard surveillance, and also working with the community. For patient care process, we expand it to part 3. This also the comply with the many standard and also working together very well with many kind of standard. For instance, the JCI standard, that is the for the patient care standard, is also come along together very well. And also the DNVGL have another standard of from DNVGL, like a hospital accreditation. So we learn from many standards to improve the HA standards as well. Paul have said to you all of these elements, the 18 elements in the MIR standard. And for infection control, this is from the HA. HA divide the infection prevention and control into 3 categories. First is for the organizations. Here, that is for the policy, and the second is for the practice and process, and also part 3 is involving the method of surveillance for the infection control in the hospital. When we see at each part of HA standard, you will see that they come along together very well with the MIR program, and also I think the MIR program also getting into detail and expand our knowledge, and also we learn a lot from MIR program to magnify of this. For instance, the focus of prevention and control here, the important infections, we have to consider what is our context. Do we have a lot of chance to see the MERS patients or patients who having the Ebola infections? Not very much. But what we have, what we are seeing every day is the patient who having the kind of contact precautions, like a MRSA or C. diff, or even the Acinetobacter baumannii that is the spreading in many hospitals. So using the same concept for the contact precautions with our context, we set up the goal and objective. So this is the thing that we learn from each other when we in the training program for the MAR. And also the infection prevention and control here. How can we educate both our staff and also patients and also patients' families? How we educate them and empowerment them to be one part of a team to prevent infections in the hospital. Because Paul said to you that is for infections, when you infect someone, you cannot see the immediate consequence. The consequence or the result from contaminated to the patients might showing symptoms a few days later, or even showing long times after that. For instance, Jakob-Creutzfeldt disease or mad cow disease that might take 10 years before the symptom occur. If you contaminated patients with that kind of infection, you cannot see immediate result. How can you tell your staff of the importance of how they caring for the patients to prevent infections or preventing them to harm the patients? And we go into detail of the standard, that is how they will design the program for infection prevention and control, and also how can they manage of the resources, providing the resources for infection control. Some hospital might say that their hand hygiene compliance very high, but when we look around, there is the very few of alcohol gel or very few of the basin to wash the hands. So if it become contrary, we should ask that is how can they achieve very high rate of hand hygiene. The organization ensures appropriate practices to prevent nosocomial infections. This is also in the HA standards. And also, when we seeing this, we see here working area with unique concern. We might think of the OR as the doctors and nurses, but just as Paul having said this, it's not just the doctor and nurses, it's also involving CSSD, it's also involving the porter when they bring up the patients to the operating room, it's also involving with the stretchers. How clean this is? How do they clean the stretcher after they bringing in the patients? And when they move the patients to the operating tables, after the operation, how do they clean the bed, the operating bed? And also the environment of the room for the ventilation of the operating room. When we say that the operating room should have positive pressures, should have the laminar flow, and Paul showing to us using the smoke, and then we see with our own eyes that it's not quite what we designed or what we intended to do. When we intended that the air or the laminar flow should come from the top of the room and then go through the patients and then go through the exhaust at the wall. So when we use the smoke, we found out that there are many things to obstruct the airflow. So instead of the airflow from the ceiling through the patients and then through the wall, it's not like that. It's come from the ceiling and then it whirling around the operating table. What does this mean? It means that if there is dust or anything, contaminations flowing around or someone walking around the operating table, they have a traffic in the operating room. The dust is just stirring around the patients and then getting into the wound. If the patients have their laparotomy open in the abdomen, the contaminated material can flow inside. So it's very scary when we see with our own eye with smoke. The organization perform appropriate method of surveillance. This also is involved with recognize. How can we recognize the importance of the issues? How can we tell our doctors to stop using the third generations of the cephalosporin instead of the first generations when they encounter the infections? Or how can we tell our doctors that the antibiotics is not the medications to reduce the fever for the patients? Many doctors use antibiotics instead of using paracetamol to reduce fever. How can we tell our doctors the importance of using the appropriate antibiotics or using at the right time? So it's very difficult when we handle with the real situations. And so the HAI and DNVGL, we working together for a while, the cooperation between HAI, and we learning from each other to apply the concept of risk assessment and bring it up into practice. And also we use the managing of infection risk as a theme for implementation of the standard. We found out that all the 18 elements is cover everything in the HA standard as well. So when we're using it together, we understand more of the standard, and we also think that this will benefit the hospital when they use both standards together. So I would like to suggest that the hospital intend for applying for advanced HA standard should learn from standard in the MIR program. and using both of these standards together to intensively implementation of a standard, because the both standard will bring all of your staff at every levels together for the quality improvement. Yeah, thank you very much.